Hello and welcome to the show Beyond the Journal, where we will discuss social media, digital education, and current controversies in cancer and medicine. I'm Dr. Jack West. I am a medical oncologist and an associate clinical professor focused in thoracic oncology at City of Hope Cancer Center in the Los Angeles area. And I'm very happy to be joined by Dr. Charu Aggarwal, who is an associate professor in medical oncology, also focused in thoracic oncology at the Abramson Cancer Center at the University of Pennsylvania in Philadelphia. Hi, Charu.
Hi, Jack. Today we are pleased to welcome Dr. Julie Gralow, who's the Jill Bennett Endowed Professor of Breast Medical Oncology, Director of Breast Medical Oncology at the University of Washington School of Medicine, and will be coming into the role of Chief Medical Officer for the American Society of Clinical Oncology as of February 15th, 2021. Such a pleasure to have you here, Julie. Welcome.
Thanks, Charu.
There are so many hats that you've worn over the past several years and such an illustrious career you've had. I wanted to focus in on one aspect of your career. You've really had a prominent role in advocacy, and you founded the Women's Empowerment Cancer Advocacy Network, or WeCan. I would really love for you to take us behind the scenes and how it began. What are some of the most remarkable achievements or memories from this experience for you?
It's fun to think back on the origins of it, and that was actually in the late 90s when I was a young assistant professor in Seattle and focusing in breast cancer. And I was approached by a local Seattle-based nonprofit called PATH. It used to be Program for Appropriate Technology in Health. Now it's just PATH. And they were putting together an application for a Ukraine breast cancer assistance program that was a request for applications from USAID. And the idea was that we knew that Chernobyl had happened, and we knew that, post the dissolution of the Soviet Union, Ukraine was likely going to have an increased rate of breast cancer from the radioactivity, and also because they were now an independent country, they might need some support. So the U.S. government decided to pick breast cancer as a target with some money. They worked with the Ukrainian Ministry of Health, and PATH got the project. So they asked me if I would serve as the medical oncologist, and I had no experience with global oncology at the time, no particular experience in the former Soviet Union era, but I said, this sounds really interesting. So I said yes. So it's one of those things where you think about the pathway taken, and I said yes. So over a 3-year period of time, we did several projects. I ran a chemotherapy protocol in Odessa in conjunction with a medical oncologist, basically to show that the Ukrainian women could tolerate conventional doses of chemo, because the thought at the time in the Soviet Union had been, because of diet and other things, they needed reduced doses. So of course they had reduced efficacy. So that was one of my projects. But the most important enduring piece of that was that there were a group of participants in the project on both sides, the Ukraine side and the US side, who decided to help enhance dialogue between healthcare providers and patients, because at the time it was still the old don't speak, don't tell you don't tell a patient they have cancer. If you read Solzhenitsyn's Cancer Ward, you'd see that was kind of, they thought they were doing it to protect the patient. I mean, it was that they thought that people would think that they would die of their cancer, and so you didn't tell them, and yet you had to treat them. So of course they knew that they had cancer. They were in a cancer hospital. They were getting chemo, but there was no dialogue around it. So anyway, that project led to the development of breast cancer advocacy groups, the Amazonka, in Ukraine. And I promised them, as the project ended, that whenever I was in the area, whenever I came back for a talk or something in Europe, I'd stop by and see how they were doing. And I did, and I watched them develop and stopped by and saw them, gave some talks, took them out to dinner a couple of times. And by 2003, we decided to have our first, what became WeCan meeting, where I brought together the advocates from Ukraine with advocates from other countries in the former Soviet Union. So we did it in Lithuania, the first one. The Lithuanians hosted it. And we had about 10 countries come together, and they shared their projects, their ideas. We gave them some education, evidence, let's use evidence to make decisions. And that's how WeCan got started. It was breast cancer at first. And then, as the cervical cancer agenda became more prominent with the UN and the WHO, and we had the HPV vaccine and all, we added cervical cancer because we wanted common women's cancers to be the target. And then, so every 2 years, we've had a WeCan conference in Eastern Europe, Central Asia since then. And then because of the Hutch relationship in Uganda, I was approached by the Uganda Women Cancer Support Organization, UACASA, to do the same thing in Africa. So that started in 2013, and we've had 6 African conferences. Now, the one in 2020 scheduled for Malawi has been postponed, but we hope to have it later this year. So that was how it all started. I accidentally fell into it. I said yes about a project that I thought was interesting. I bonded with these, women. I actually saw my patients in Seattle who were struggling with survivorship and how do we get back to normal and how do we get healthy lifestyles, and all. I saw that connection and ran with it.
That's wonderful. And I think you've been a pace setter in global oncology, a field that has really grown over the last couple of decades since then, and I think it's really quite gratifying to see that it is now an area of more and more study and dedication. Over time, as the world has become more digital, as we share information and have advocacy groups that may be more in the online space, how has that changed things? Is it more of a global breast cancer community? Is there a diminishing impact of regional practices or cultural differences because there's just a pooling of experience?
Yeah. Well, we've had the digital tools for quite a while. We've had social media promoting connectivity and all for quite a while. But I have to say, COVID really helped us make a big jump because the traditional everybody comes together face-to-face kind of meetings were still going on, and that takes a lot of travel and time zone differences, and all of that. But what happened with COVID when we were forced to deal with it is we were able to figure out, we all have PhDs in Zoom now, I think, we were forced to figure out how to do these conferences. I mean, just in the past 2 months, I've been able to, I did a conference in Nigeria, in Egypt. I did Best of ASCO Africa, which the Uganda Cancer Institute was a sponsor of, among other sponsors. I mean, I was able to do all of those things from home, admittedly, some in the middle of the night because of time zones. But so we actually, many more people have been able to join in who would not have been able to travel. And I can't tell you, visas are still a big issue with respect to face-to-face travel, totally separate from COVID. We've had plenty of conferences, even my WeCan conferences, where I've got to help the advocates get into a country and, the permission to get a visa to even come for an educational conference is a problem. So I think COVID has pushed us even farther into this connectivity. I mean, when I was participating in the Best of ASCO Africa, we had participants from all over the continent, but also Europe and United States and Canada participated. And there was real, activity interchange. It was really amazing to see that come together. and to see all that cooperation. I've watched.
I mean,
yeah, go ahead.
I'm sorry, if that's one big positive of COVID, we'll take it, right? Let's bring the global community really closer together.
Absolutely. Yeah.
So you've really, your work in global oncology has focused on women's cancer, started with breast cancer, and you talked a little bit about your experience with expanding that work to cervical cancer. But do you see that many of your experiences and the lessons learned could be translated to other cancer types? Or do you think it's harder for some cancers as opposed to others? What has your experience been?
Well, I absolutely think that it's translatable. I mean, it's not, you can't just take what we've formed and move it to another cancer type, another population, but it's absolutely translatable. I mean, as I mentioned, WeCan started with breast cancer because it was a breast cancer project. And then when it became apparent, especially as we moved into Eastern Africa, that cervical cancer was actually a bigger killer in many of these countries than breast cancer. And the issues, the sexuality, the stigma, the husband leaving the wife, all of that kind of stuff was the same no matter what kind of cancer. And the cervical cancer patients didn't have as much of a voice, and there was even more stigma because of the location of where the cancer was. And so it was the breast advocates who said, let's bring the cervical patients on. I remember the first conference that we actually had cervical cancer patients attend in Africa was in Tanzania. And one of the doctors at Ocean Road in Dar es Salaam brought a woman with cervical cancer who came from a village, did not speak English, but she translated her story about, she just burst into tears. She was so happy to be connected and to be able to talk about it with somebody. And, she had the support of her oncologist who brought her, but also all these women now were supporting her. So we added cervical. While because of the education and the evidence piece, I'm not sure we want to add a lot more cancers to WeCan. I think similar models, where we have a focus on different cancers could be done. Back in the U.S. in '95, I co-founded a group called Team Survivor Northwest to get the healthy exercise and lifestyles into women cancer patients' lives to help them with that. And I wanted it to be for all women cancer patients and survivors, not just breast. Some of our funders early on would only give us money if we would just restrict to breast. So we actually turned down money because of that. And because the women said, a lot of these issues are just similar across all of the disease types. They're more about what do I do with my children or my partner or the sexuality piece or whatever. That had nothing to do with the cancer as much as it did just with, the consequences of the treatments, right? So I do think it's translatable. And I would encourage other groups. We can have brought in some survivors of some other diseases just so they could see what it looked like, so they could get ideas about how they wanted to take it.
You'd mentioned silver linings or positive aspects of COVID is that it's lowered some of the barriers like state licensure for telemedicine. And of course, I also practiced in Seattle like you, and there's people who are coming from several states away to get tertiary care or consults, and sometimes a lot of their primary management directed by folks in Seattle. But telemedicine in the pandemic has been a critical benefit, shoring up the limitations of in-person visits. Can you speak to the benefits that you have seen and felt from it, as well as maybe some of what you see as limitations? Because I think there are plenty of people who feel the connection isn't there. Obviously, you can't do a good exam, a meaningful exam in the same way, but how much of a benefit does it provide for your patients who are coming from Alaska or Montana or something? And after the infectious risk declines, do you envision or would you want to see it as a permanent tool alongside live visits, both you personally, and what do you envision ASCO's position might be with the power it has?
Yeah, ASCO just last month came out with a white paper, the road to recovery, cancer care and research in a post-COVID era, which I think kind of tries to start at least addressing some of what are the good things and the bad things. What are the things we don't want to continue post-COVID, but what are the good things, the silver lining things, as you say, that would continue? So I've seen benefits of telemedicine both in clinical care and in our clinical trials, and we can take that into two different pieces. In the clinical care, as you say, in the Pacific Northwest, the University of Washington is the academic medical center for a 5-state region, right? Washington, Wyoming, Alaska, Montana, Idaho. And we also are right next to Oregon, and Hawaii's out there too, even though they have medical schools. So that's part of our mission, actually, is to care for that whole region. And we're not the East Coast, very dense with a lot of different cancer centers, and you have, a whole bunch of great centers in a small area. So it's been really interesting. And this whole telemedicine piece, I was following it from, early March. And what are the rules? What's allowed? This cross-state licensure is the main thing. I mean, I think we solved the HIPAA and the security of it pretty quickly, and then we solved at least the temporary billing piece of it, but, that's another piece that's on hold. It's kind of temporary. We don't know where we're going to go. Do we get to bill at the same level? What's going to happen when COVID ends? So we had the billing piece of it, but the most important piece when you talk about these, us in the Pacific Northwest, or me now, you're not here anymore, is the cross-state licensure issue, because wherever the patient is where you're practicing medicine. That is the interpretation. And I'm licensed in the state of Washington. I now have a pandemic license in the state of Montana. We actually had to create a position of a telemedicine expert at the Seattle Cancer Care Alliance, who, on a weekly basis had to look up what each state was allowing, in terms of the licensure waiver or whatever. Some of the states in our area said, during the pandemic, we don't care. Just do what's right for the patient. Others said, absolutely not. We are not giving any cross-state, approval. Well, that was Oregon, and just yesterday, I did a consult on somebody in Pennsylvania, a one-time consult. And I needed the help of my telemedicine expert, and I know what the rules are in Pennsylvania, and I notified the Board of Medicine, and they acknowledged it and were very nice. They said, thank you so much for providing care to this patient, which was lovely to get that kind of response from the Board of Medicine. But so our site, a big cancer center, can afford to hire somebody like that. Who knows what all the different licensure issues are now, who can look it up on a weekly basis and see what's changed, who can keep us from risk, because that's the risk. You're practicing without a license if you're doing this. And we even said, what if we just did it in some of these states and didn't bill for it? And they're like, if you document a note, you could still be at risk, So I think we'll see what happens. I would love to be able to continue to offer it. The negative is that bond. But I've just noticed how much, even with COVID, I didn't think I was a huggy person, but I realize now, especially since I'm saying goodbye as my last visit with a lot of patients, I do like that close interaction, to be able to give a little hug at the end of the visit. You can't do that by telemedicine. You can't do an exam by telemedicine. And, so you're going to have to see patients face to face for certain things. And so that's just not going to go away.
Julie, you're going to be starting in about a month as the Chief Medical Officer of ASCO. And, you've had obviously a really clear role in global oncology. I mean, you've looked at some disparities as well as, issues as they relate to the direct cancer care of women, as well as other cancers. ASCO is thought of as a very, it's obviously the American Society of Clinical Oncology, but it has a very global presence. How do you envision your role as a CMO of ASCO in advancing really this mission that you've had for a while with regards to disparities, equity in the global setting?
Well, ASCO's current 5-year strategic plan has 4 major pillars, one of which is global. So ASCO has taken this on as being a key part of our 5-year strategic plan. We know that at our annual meeting, half the attendees are not from the United States. We know that our membership increasingly is from outside of the United States. And so while we have a responsibility to those practicing oncology in the U.S., this is their society after all. But this, we are increasingly becoming global and wanting to support access to cancer care, state-of-the-art cancer care, no matter where you live. And so we have to help the providers be able to, understand quality care, what new expensive drugs are worth it in the big scheme of things. We have to connect with the WHO, who creates an essential med list that actually really every 2 years seeks submissions for new drugs to be put on the essential med list, reviews them, looks at cost benefit, the now increasingly ancillary testing required to know if you're eligible for a therapy, and can these countries even do that kind of testing to determine a drug. So that's, ASCO feels this is important. I led the ASCO Academic Global Oncology Task Force report. I've been the co-chair of the ASCO Resource Stratified Guideline Working Group, where we take our ASCO guidelines, which are written for the highest level of care, right? And then we try to translate them into pieces that are resource appropriate, culturally adaptable, et cetera, in terms of what should be the basics that you provide that's not very expensive. What's the next level that you would work toward? What's the next level? Instead of jumping to the most expensive triplet of immune checkpoint inhibitors or something right away, let's get good, solid, less expensive, but still, effective treatment. Let's make sure we can adequately assess who benefits from which of these new targeted therapies before we start adding all of these drugs. So the World Health Organization's Essential Med List helps because they help do that assessment of where's the best bang for the buck, what's the minimum amount. Most of the drugs on that are generic, because they're, they're cheaper. So that's one piece, is just the resource stratification, the commitment to evidence. So ASCO, has the 3 pillars, just like, academic medicine, the education piece, which includes training, the clinical care piece, and the research piece. And so we want to promote evidence and promote the best, but also help our colleagues around the world be able to adapt that to something that is appropriate with the resources, the cultural issues, et cetera, in their own countries.
I'd like to follow up. One of the things that we're struggling with debating in lung cancer now is something that I think the breast cancer world has preceded us in the meaning of certain endpoints. For instance, we now have the ADAURA trial that has shown a colossal improvement in disease-free survival in the adjuvant setting that we don't have overall survival for yet. We have impressive but early data on neoadjuvant therapy improving pathologic near complete response or complete response. Of course, the breast cancer community has been working in this setting and dealing with some of these issues earlier. How much or how little does that vary by where you are in the world? And are the thresholds different in the U.S. versus Europe, or places that are where resources are more limited? And do you see a potential or a value in a more global international standard?
Yeah. Well, as I'm easing into my ASCO role, I'm increasingly learning a lot of things, and I'm learning how much the FDA's decisions and statements impact a lot of these other countries that don't have the ability to have the same kind of regulatory oversight. And so, we've got the EMA in Europe, right? So that can speak for a lot of countries. But then even if the EMA approves something, each individual country decides if it's going to get put on, their, be able to be used, put into their pathways, be covered, basically. So you're right. The breast group is a little bit ahead of the lung cancer group in dealing with this. I mean, you walk the line of wanting to get the drug to the patient as soon as possible. If you've got a promising agent and you've got, and they have metastatic disease, if you wait for the overall survival endpoint, they may be dead. They might not have access to it. So we want to get promising agents to patients as soon as possible, and really making sure they're safe, right? That the risk benefit weighs out in favor. Is one of the key pieces of it. And then having this kind of preliminary approval or accelerated approval based on a surrogate endpoint that needs to be locked in with a more definitive phase 3 trial or a more key endpoint, such as overall survival, right? So, what we saw in breast cancer was we actually had an accelerated approval of bevacizumab in metastatic breast cancer based on a real strong improvement in progression-free survival in the metastatic setting, but that never translated to overall survival. And across a couple more studies, it didn't either. So it got revoked. So in breast cancer, we had temporary approval of bevacizumab, but it didn't meet the requirement to lock in the full approval, although actually it's still approved in Europe for metastatic breast cancer. So the long and the short of it, Jack, is I think these surrogate endpoints that are much quicker, that seem to have some association with the key endpoints, disease-free or progression-free survival, and ultimately overall survival, are key. But I think, we've walked that balance of, is it a good enough difference? Is there enough safety present? Is it consistent, across multiple trials that might be going on to let patients have access to it while we further study it? And so you asked about how does that translate globally. I think when I wear my thought leader hat and I'm talking about, telling the Ministry of Health, the Ministry of Finance, what should be on, their formulary. Right. The ones that have the full FDA approval, that have locked in for the important endpoints, where the difference is not just statistically significant, but clinically meaningful. That's another thing. We've got some gigantic studies with thousands of patients that met a statistically significant result, but it was like a 1% to 2% difference. That's a game of statistics. And I think we all have to step back, and we should do this in the US too, and say, is that clinically meaningful? And in low and middle resource countries, that tiny difference is probably not, right? And so that's part of the whole quality piece too, is if you're kind of weighing a benefit and a risk, a financial piece of it, how does the drug fall out? And you've got to rate it on all of those things. Plus, we've got to, some of these drugs are quite toxic. So we've got to also be sure that, we are appropriately informing our patients. So I think it's important in the US to make sure we understand our endpoints and force a real, true clinically meaningful endpoint and result. But it's even more important in countries where their dollars to spend for drugs are much, much, much less.
Yeah.
I'd like to change the topic slightly, Julie. And, there's been over the years, I think growing attention towards gender equity, mainly in medicine, but also, as we look across organizations, they're paying a lot of attention to, equity in terms of grants, in terms of awards, in terms of opportunities, not just mentorship, but also sponsorship. Has this been an evolving challenge over your career? And if so, do you feel like we're making meaningful progress? Do you think we can begin to sort of say that we're moving toward the more equitable future for our young faculty and fellows?
I think we've increasingly recognized it over the course of my career, that this is something that exists as a problem, and that we need to be working toward correcting it. I think so. The recognition of it has increased. I think the data and the evidence to support it, and to support some of the more subtle things that aren't apparent. Some of this, discrimination or inequity is a little more soft and a little bit harder to call. But for example, I think the ASCO 2019 meeting had some great session and plenary presentation kind of addressing some of this, a really fascinating presentation that just based on how do we introduce female versus male speakers, and demonstrating that, the male was introduced with the doctor title more often. Women were more frequently introduced as speakers by their first name, all of that kind of stuff. Those kind of subtle things, that's a respect thing, right? And so just kind of looking at it. And I think as a consequence of that ASCO 2019, one of those sessions, I think Francis Collins made a statement saying he would no longer serve on a manel, he called it, an all-male panel. So if he was asked to be on a panel, he would insist that, there be gender equitable representation. I think, I think we formed more women's groups to mentor each other and to support each other. I spoke and participated in a great conference on women in oncology, the LEAD conference, which was really about learning from each other and looking at different career pathways, supporting that, yes, it's okay to take time out to have a pregnancy, and but what are the issues with getting back in to the workplace again? How do you manage some of the the more traditional maternal roles and caring for your kids, so I think there are more and more and more opportunities for the younger generation coming up in oncology to connect and learn, and support. Support is a very, very key thing too. The ASCO several years ago started at the annual meeting. There was I'm not quite thinking of the term, but like a breakout room, a room where women could come in and they would ask people who were more senior, would you agree to do a couple half-hour mentor things? And then the junior people could sign up for who they wanted to be matched with and stuff. And then you'd meet in this, this women's center and connect over coffee or something, and just, I've had relationships there, that we continue. We touch bases a couple times a year, give support, give ideas, try to help make connections. So I think that we've seen more recognition. And I think that those of us who are more senior now have really wanted to participate as, kind of mentors to help the younger generation kind of tackle some of the things and be more visible and talk about it more, as a group. So I am hopeful that we are going the right direction. And I think a lot of people, there's this hashtag on Twitter, he for she, right? Men who are supporting women. I think we've got a movement going, and maybe it's not, going as fast as some people would like, but it's going in the right direction.
I'd like to talk a bit about, we discussed telemedicine in practice. You have been deeply involved with SWOG and as well, ASCO, of course. One of the most challenging aspects within oncology of the pandemic has been the decimating effect on of the pandemic on clinical trials, enrollment, et cetera. And I know that you've done some work exploring how telemedicine could be applied to change how we run clinical trials, to minimize the burden of all of the transportation visits and live visits for labs that could be gotten close to home, et cetera. I'm a little afraid that we will cure all of coronavirus before we change the sclerotic processes of the hyperregulated system that has a lot of incentives to make it as burdensome as possible from CROs, et cetera. Can you speak to whether we can have any optimism with efforts from SWOG, ASCO, and others that this will ever change and become easier? Because it's clearly a disservice for patients as well as the whole field of oncology and medicine.
Yeah. So, just keeping the pace of research during COVID has been a challenge. And I think what it forced us to do was recognize how many of the visits that were mandatory and the timeframes that were set around them really had nothing to do with the quality of the research, and that we really needed to loosen a lot of that up, not just during COVID, but in general. I mean, there are just some of the things that are part of clinical trials, just there's no good reason for them. And so, during COVID, some trials got shut down temporarily, others kept going. All of our trials are back up and running again within SWOG and at the UW Seattle Cancer Care Alliance, Fred Hutch. But I think what we found was, and again, being in the Pacific Northwest and having my patients enrolled in clinical trials across multiple states, having them come in for a visit where you're just really reviewing their symptoms, and that's the only thing you're doing, really. I mean, you're taking their blood pressure, their weight too. That could be done by a community physician out where they live, right? And then you could do a telemedicine visit reviewing their symptoms and not make them travel if that's really the only thing you're doing. And, this mandate about where you have your blood drawn or where you have your scan, we need to be we need to make sure that there's good quality laboratory information and good quality scans that come out of it, but we should be able to certify across a whole bunch of sites, not mandate that they come, to the site that enrolled them that got certified. So, we just, so the National Cancer Institute and the cooperative groups kind of issued some temporary restrictions, loosening of timeframes, loosening of where you're seen and all. And I'm hoping a lot of those will be, permanent now that we've seen the advantages. We've even talked about consenting patients by telemedicine, because a lot of times you see a patient, you present a trial at a visit, but they want to think about it. And then you'd have to bring them back again, for a visit where they sign the consent. And that's a visit they don't need to come back for. So we've actually allowed in, some settings the ability to do that consent visit by telemedicine or online. So that's the cooperative groups. I just had to sign off on an interesting memo of SWOG's interpretation for patients on clinical trials about the ability to get the COVID-19 vaccine, and that we actually had to make a clear statement that it was not considered investigational, because there's always that thing, you can't get an investigational treatment or something. So we had to make it a very clear statement that for purposes of any SWOG trial, that it would not be considered investigational and you could get it. But we had to come up with a memo for that. And so, we participate in industry trials and especially registration trials. And, I have to say, we're going to need to do some work with industry, and hopefully the FDA will help support us, that a lot of the stuff that they think they need to do, especially for a registration trial, it's going to be audited and everything, that there can be some laxity or not such strict criteria for it. The CROs ROs do what they're told to do that's built into the study. And the study is designed, especially in a registration setting, so it can be pure. No comment is going to be audited. You want to make sure everything's perfect. But there are so many extra things that we do that are just not helpful. They don't tell us anything about the efficacy or the safety of the drug. They're burdensome. I constantly sign off on study deviations that are these little tiny things, especially during COVID. They were outside the window of, the time of the visit. And I've got to say, did it harm the patient? I can't tell you how many of those I've signed, for tiny little things where it was like off by a day or two. So, the first part of ASCO's Road to Recovery report, the first half is all about clinical trials, things that we were able to do during COVID that we either want to keep or don't want to keep. And then the second piece was on the clinical care. So the whole first piece addresses the clinical trials thing. I think we need to be a little more nimble and flexible.
Yeah.
And that's what I love about ASCO's TAPER trial and Centra. I don't think ASCO should be in the business of competing, with the NCI trials or with industry trials. But I think that the Centra program and then the TAPER trial, which does genomic profiling and matches drugs that are already approved by the FDA in some setting. So we know the safety, right? At least, and we try to match it to genomics. That's more of a registry, in my mind. And so it's set up. We've got a lot of sites and participants in that. And because it's ASCO, we can modify, we can change, we can adapt. We don't have to be quite so strict about things. We can gain the evidence that comes from having a lot of community sites and some academic sites participating in a registry project, where we're getting access to all these drugs. So you don't have to write a single patient IND when you want to get access to a drug, which is like impossible for a small community practice to have the ability to do that. You'll get the drug every time if you actually do that, if you actually write it. I've learned that, but it takes a ton of time to get that single patient IND. And so, having that kind of registry, set up and that network set up, we were able, when COVID hit, to quickly also, have that same network reporting on their cancer and COVID patients. There's a lot of networks that are dealing with cancer and COVID, but we're going to have really long-term good follow-up with a lot of details about exactly how they were treated and what their outcomes were, et cetera, by having that. So I tell you about that. I'm excited to be taking that over. I'm pleased to say that Rich Shilsky will stay on as the PI of the TAPER trial, at least for a while, so I can learn everything else I'm supposed to be doing at ASCO. But I think that flexibility is going to be key as we move forward in clinical trials, because there are way too many things that we do for no good reason that make it difficult, and the paperwork and all of that is just got to stop.
So Julie, it's just such an amazing conversation we've had with you today. And just, in the last 40 minutes or so, I've begun to realize how many things you've said yes to over the years and, which are clearly, led to some amazing accomplishments. But also, when you're saying yes, there is a component of your life that you're saying no to, be it anything, be it your personal side or be it, let's say patient care. How do you make the decisions to actually say it's okay to say no? For example, you're now, stepping into your new role and you're saying your final goodbyes to your patients. How have you made these decisions over the past few years or over the course of your career?
Particularly because so many other people are going to have to be prioritizing what you say yes or no to as you shape your career trajectory.
Well, I think, one thing that I've used to lead me in my decisions of, am I passionate about it? And that's where it took me the global route, the advocacy route, kind of. I thought that was really important. Another piece of that is, are there other people already doing it who are doing a great job, or am I somebody with my skill set, with my interests that could really take this on and move it majorly? And some of my yeses have been that because of, my experience and where I am and my stature and everything, I can get in and meet with key people or, make a statement and it'll be listened to more. So those are the kind of components of, can somebody else do it? and am I passionate about it? Now, more and more, I've had to say no as I become more senior because I get asked to do a lot more things. But I do try with the no to think of somebody else who might be a good fit for that and offer it as an opportunity to somebody else. So one, the group asking me to do it is benefiting from that, but also that's part of my mentorship role, which is my life is, now mentoring. And can I find it as an opportunity for someone else? So that makes it easier to say no. I think, there's a trick, there's a balance in academics as well as community practice too, between, your work, your day job that you have to do, your home life, and then your hobbies. Global oncology was really, in my mind, my hobby for many, many, many years because I was getting no academic credit for it. I really wasn't getting support. I was doing it on top of everything else. And I do have to say, one of the reasons I could do that and I could do these other things was because I had the most amazing team that I worked with in Seattle, between my colleagues in medical oncology, our advanced practice providers, my nurse, my scheduler, my administrative assistant. I couldn't safely have my complicated patient panel if I didn't have other people who were going to be there helping and take care of it so that there was no risk if I was going to be on a flight for 12 hours somewhere and I wasn't reachable. So all of my successes really come from having that kind of team behind me, that's allowed me to do these kinds of things. And hopefully I've given back to them. And it's been rewarding for them as well. Some of them have joined me on some of my international trips. My service line manager came with me to Uganda last year and really hit it off and helped them develop metrics and stuff, so I try to do some reward in exchange for all the help that they give me too. So, you have to say no sometimes. And sometimes saying yes is a little scary. You're not quite sure where it'll go. You also have to be able, if you said yes and it's not going the way you thought it was, it's either too much work or it's not going the direction. You have to be able to back out of it again too at an early time point when you see it's not going where you thought it was.
This was amazing, Julie. Thank you so much for taking out the time to speak with Jack and I, and thank you for joining us today. You can find us on iTunes or wherever you find your podcast content. We hope that you will subscribe and send us comments and feedback to beyondthejournalshow@gmail.com. We would like to thank Mark Lindsay and Talking Speaker for production and distribution support. See you in a couple of weeks with our next guest. Thanks, everyone.
Thank you so much.